Before your doctor walked into the room, there was already a number, a risk score, calculated from your history, your costs, your conditions, designed to predict how much care you need. It was designed to be fair. It was not. This is not a story about a rogue algorithm or a bad actor. This is a story about a system trained on history, and what happens when that history is one of unequal care. There is a score attached to how sick the algorithm thinks you are. It was calculated before you walked in, and it was trained on data that already reflected a century of unequal care. By the end of this video, you'll know whether a health algorithm may have already made a decision about your care, and exactly what you can do about it. This is the pre-diagnosed. Healthcare algorithms are not new. Hospitals have used computerized scoring tools for decades. What changed in the last 10 years is scale. And what changed in the last 5 is the use of machine learning, systems that teach themselves from historical data. Today, algorithms are used to decide which patients need extra management programs, predict who will be readmitted to the hospital within 30 days, score how much pain a patient is likely experiencing, estimate insurance premiums, prioritize who gets a specialist referral. All of these tools are trained on historical data. And here's the problem that sits at the center of every one of them. If the history the algorithm learned from was unequal, if Black patients historically received less care, were dismissed more often, were undertreated for pain, then the algorithm doesn't just reflect that history, it reproduces it. In 2019, a team of researchers at UC Berkeley, Brigham and Women's Hospital, and the University of Chicago decided to look inside one of these systems. What they found was published in Science, one of the most prestigious peer-reviewed journals in the world. What they found was not a small calibration error. It was a structural distortion, built from history, running at scale, invisible to every patient it affected. And it changed how regulators, hospitals, and the entire AI industry think about health algorithms. Ziad Obermeyer is a physician and health policy researcher at UC Berkeley School of Public Health. He studies how algorithms make decisions in medicine. In 2019, he and his colleagues got something almost no outside researcher had ever obtained: access to a commercial health algorithm and the data it was trained on. The algorithm was sold by Optum, a health services division of United Health Group, one of the largest health companies in the United States. The algorithm was called Impact Pro. Hospitals used it to identify high-risk patients who would benefit from extra care management, coaching on medications, extra check-ins, preventive interventions. The idea: identify who's at risk before they end up in the emergency room. It was used across healthcare systems affecting an estimated 200 million patients per year. Obermeyer's team ran the analysis. They looked at patients with the same risk score, the same number the algorithm had assigned, and asked, how sick are they, really? They measured actual chronic conditions: diabetes, anemia, hypertension, kidney disease, clinical markers, not cost predictions. And they found something that should not have been possible. At the same risk score, Black patients were considerably sicker than white patients. They had more chronic conditions, more signs of uncontrolled illness, more biomarkers indicating deteriorating health. The algorithm had ranked them equal. The algorithm was wrong. Now here is the part that makes this more than a story about one bad algorithm. Nobody programmed it to discriminate. The word race did not appear anywhere in the model. The algorithm used healthcare costs as a proxy for healthcare need. On the surface, this seems reasonable. If someone spends a lot on healthcare, they probably have a lot of healthcare needs. Cost is measurable, available in every hospital's billing system, and easy to compute. But costs are not race-blind. Because of decades of structural inequality, less access to care, less insurance coverage, lower incomes, implicit bias in clinical settings. Black patients spent less on healthcare than white patients with the same chronic conditions. Not because they were healthier, because they had received less. The algorithm looked at that gap and concluded, this patient costs less. Therefore, this patient is healthier. Therefore, this patient needs less care. It encoded a century of underfunding as a medical fact. The consequence: the algorithm identified Black patients for extra care at a rate of 17.7%. If it had used actual health need instead of cost, that number would have been 46.5%. Less than half the Black patients who needed extra care were being identified for it. Optum responded that the study's conclusions were misleading, that cost was just one of many data elements intended to be used to select patients, and that doctor expertise was expected to supplement the algorithm. But the research team worked with Optum directly. Optum independently replicated the analysis on a national dataset of 3.7 million insured patients. They confirmed the bias. They fixed it. Reformulating the algorithm to use actual health need instead of cost reduced racial bias by 84%. One algorithm, fixed, for this company. But the logic that created the problem, using cost as a proxy for need, is still embedded in systems across the industry. If you or someone close to you has ever felt dismissed by a healthcare system that seemed not to see how sick they were, say so in the comments. Patterns matter, and this one has a name. The Obermeyer study focused on one algorithm from one company. But the researchers were explicit. This is typical of an industry-wide approach. The same proxy logic, using costs, utilization, or spending as a stand-in for health need, runs through many of the tools used in hospitals and insurance systems today. In dermatology, AI diagnostic tools trained primarily on images of lighter skin have been documented to misdiagnose conditions in patients with darker skin. A 2018 study found that dermatology algorithms perform significantly worse for darker skin tones. The same machines that can detect melanoma in a white patient may miss it in a Black patient. In pain assessment, multiple studies have documented that algorithms used to score pain levels are less accurate for Black patients, reflecting the same bias documented in human clinical settings, where Black patients are systematically undertreated for pain. In sepsis prediction, models trained on data from predominantly white hospital populations show lower sensitivity when applied to Black patients, meaning the early warning system is less likely to flag a Black patient before sepsis becomes critical. In every case, the mechanism is the same. The algorithm was trained on historical data. The historical data reflected existing inequalities. The algorithm reproduced those inequalities at scale. In July 2024, something different happened. The Department of Health and Human Services finalized a rule under Section 1557 of the Affordable Care Act, the ACA's non-discrimination provision. The rule prohibits discrimination on the basis of race, color, national origin, sex, age, or disability, including when that discrimination is produced by an AI tool or algorithm. Covered entities, hospitals, clinics, insurers must take reasonable steps to identify and mitigate discriminatory impacts of any algorithmic tool they use. This is different from the stories we've told in the last 2 episodes. The data broker rule was proposed and withdrawn. The workplace surveillance law is from 1986. Here, a federal protection exists. But covered entities must take reasonable steps is a standard that will be defined case by case. Most patients have no idea whether the algorithm their hospital uses has been audited for bias. Most patients have no idea an algorithm is involved in their care at all. The protection is real. The transparency is not. There is something important Obermeyer said after the study was published. He said, "The algorithm did exactly what it was built to do. It predicted costs accurately. The problem was that cost and health need are not the same thing in a country where access to care is unequal. From a risk governance perspective, the frameworks I work with professionally, this is what we call a proxy variable problem. You measure what's easy to measure, and then you optimize for the measurement, not for what it was supposed to represent. The algorithm was not built to be racist. It was built to be efficient. Those two things can produce the same result." This is Shadow Structures, where we investigate the systems that shape your life without you ever seeing them. If you want to understand what happens when this same proxy logic enters the criminal justice system, the algorithms that decide whether you go to jail, subscribe. Next, the pre-crime score. Before the full picture, I need to say something directly. If you or someone you love has ever walked out of a doctor's office feeling like they weren't taken seriously, if you've ever been told your pain was less than it felt, if you've ever had the sense that the system had already made up its mind before the appointment began, there may be a number behind that experience. Not every case of feeling dismissed is algorithmic. Humans carry their own biases, documented, studied, persistent. But algorithms run at a scale humans cannot. When a biased human sees 50 patients a day, 50 people are affected. When a biased algorithm scores 50 million records, 50 million people are affected. Obermeyer put it this way: healthier white patients get to cut in line ahead of black patients, even though those black patients go on to be sicker. That is not a statistical abstraction. That is a person in a waiting room who needed more care and did not receive it. Now the full scale. The Obermeyer study documented one algorithm, but the researchers noted that similar bias is likely present across multiple systems because they share the same underlying logic. Use historical data to predict future cost and allocate care accordingly. The ACLU estimated that tools like Impact Pro, risk stratification systems that help hospitals identify high-need patients, affect tens of millions of Americans annually. Obermeyer's own estimate was 200 million. 200 million people. Tools where few have ever been audited for racial bias by an external regulator, and where those audits, when they occur, are not routine. Tools that patients have never been told are being used. The Lancet wrote, after the study, "The level of transparency, sharing, and accountability shown in the Obermeyer study is currently not common practice." That was 2019. 5 years later, the HHS rule exists. But most hospitals have not been audited. Most patients still don't know the algorithm is there. There is a score attached to how sick the algorithm thinks you are. It was calculated before you walked in, and it was trained on history. What does that mean for you now? It means the algorithm may already be part of your care, but you have rights, and some of them are new. Your toolkit. 1. Ask whether algorithmic tools are used in your care. Directly. Before a procedure, before a risk assessment, before an insurance decision. Ask, does this institution use predictive algorithms or AI tools in determining my care plan or coverage? You have a right to know. Under the HHS section 1557 rule, covered entities must be able to explain their algorithmic tools and demonstrate they are not discriminatory. 2. If you believe you were denied care or given a lower priority due to an algorithmic tool, you can file a complaint with the HHS Office of Civil Rights. OCR is required to investigate. The complaint process is available at hhs.gov/OCR. You do not need to prove the algorithm was used. You need to demonstrate the outcome was discriminatory. 3. Request a copy of your medical record and look for references to risk scores, care management eligibility, or high-risk stratification. If you find a risk score you did not consent to, ask which tool generated it and how it was validated for bias. 4. If you are in a health plan that uses algorithmic tools for coverage decisions, denial of prior authorization, coverage tiers, step therapy requirements, these decisions may be subject to the same non-discrimination rules. Ask for the clinical criteria behind any coverage denial. Ask whether an algorithm was involved. 5. Push your physician to push back. Obermeyer's recommendation after the study. Doctors should treat algorithmic risk scores as one data point, not the data point. The algorithm should inform the physician's judgment. It should never replace it. If a risk score seems inconsistent with what you're experiencing, say so explicitly. The algorithm is not your doctor, but it is in the room. Knowing it is there is the first step to making sure your doctor sees past it. The algorithm didn't know the patient's name. It didn't know their history of being dismissed, their family's history of being undertreated, the specific way that poverty, angiography, and structural inequality had shaped their access to care. It knew what they cost, and it concluded that cost was enough to know how sick they were. What Obermeyer's team proved is that this conclusion was wrong. What the health system proved, by fixing it when shown the evidence, is that fixing it is possible. What the rest of the industry has not yet proved is that they are willing to look. Shadow Structures investigates the systems that shape your life without you ever seeing them. This was the pre-diagnosed. The health algorithm decided your risk based on history. The next one decides your future. In the next investigation, algorithms are being used to predict whether someone will commit a crime before they have committed one. The score determines how police deploy, how bail is set, how a judge sentences. In 2013, a man named Eric Loomis was sentenced in Wisconsin. The judge used a proprietary algorithm score to determine how much time he should serve. Loomis asked to see how the score was calculated. The court said no. The health algorithm learned that a history of receiving less care meant you were healthier. The pre-crime algorithm learned that a history of being policed more meant you were more dangerous. If you've ever had a medical decision made about you that didn't feel right, share this. The algorithm may have already made up its mind. Now you know it exists. The pre-diagnosis runs before you arrive. The question is whether your doctor is looking at you or at the number